Hi, I'm Taofeek Owonikoko, Professor of Hematology and Medical Oncology and Vice Chair in the Department of Hematology and Medical Oncology at the Winship Cancer Institute of Emory University. Thanks for joining us, and thanks for having me to talk about small cell lung cancer treatment of relapse disease update for 2020. As we all know, small cell is one of the major subtypes of lung cancer, constitute about 13% of all cases diagnosed in the US on an annual basis. More than 30,000 new cancer patients would have a diagnosis of small cell. While we've had some recent, very promising and established new options of treating patients with newly diagnosed disease, especially the extensive stage disease patients, the treatment of patients with relapse disease remains a big challenge. The way I approach the treatment of patients with relapse disease in 2020 has to do with a number of key factors. One is the stage at which the patient was diagnosed. So someone with limited stage disease who is now relapsing after completing chemotherapy and radiation. And one has to look at that in the context of retreatment with a platinum-based regimen if their relapse occurred much longer than 6 months in general, and especially if it's more than a year. I will look at those patients as someone that I'm treating for newly diagnosed extensive stage disease and consider them for chemotherapy plus immunotherapy regimen. For patients with relapse disease following treatment for extensive stage disease in the front line, I look at those patients and then look at the various options we have. I make bold to say at this point that we probably do not have an established standard with the change in our frontline approach of chemotherapy and immunotherapy. The prior standard of topotecan in this setting is probably dated, as this came from data from patients treated only with chemotherapy in the front line. Most recently, there was the accelerated approval granted to lurbinectedin based on a single-arm phase 2 trial that showed promising efficacy of this drug. With the FDA approval, lurbinectedin is now one of our standard of care agents to use, of course, pending confirmatory phase 3 trial. It's important to also recognize that efficacy of lurbinectedin varies based on sensitivity to platinum. Response rate for those with platinum-sensitive disease is almost double the response rate with those with platinum-resistant. So when I have a platinum-sensitive patient, I'm more inclined to offer them lurbinectedin. And for those with platinum-resistant disease, it's not like we have a better option. So lurbinectedin could still be considered in lieu of a clinical trial option. Secondly, for patients who did not get immunotherapy as part of their frontline regimen for extensive stage disease, I would also consider the approved indications for nivolumab as a single agent, as well as for pembrolizumab, especially for those with PD-L1 positive tumors. Finally, we should not forget our reliance on other cytotoxic chemotherapy agents that we've been using even before the advent of immunotherapy. I still rely on single-agent paclitaxel, gemcitabine, and docetaxel in appropriate patients. There are also ongoing clinical trials now looking at liposomal irinotecan that could be offered to patients as a second-line treatment option. So as we can see, this space currently does not have a clear standard. We have an approved drug that is pending confirmatory study in the phase 3 setting. We have another agent that is currently in phase 3 trials. And then we have agents immunotherapy agents that would only be applicable if a patient did not get immunotherapy in the front line. I think I will still consider most of our patients for participation in clinical trials as the optimal treatment option for patients with relapsed small cell in 2020. Thank you.